Hello, ladies and gentlemen. Welcome to HAS 20 Virtual Summit Breakouts. During this session, you'll be able to submit questions and upvote questions from other attendees. The questions with the most votes will most likely be among the questions asked by the host to the presenter at the end of the session during the live Q&A. The bottom right tile box is where you can type in your question as well as click the thumbs up button to upvote a question. During the session on the top right tile box, you will also see a 5-question quiz based on the speaker's content. Enhance your learning by taking the quiz during the session and get points for your correct answers. All sessions will be available on demand, and if the presenter has given us permission, you will also be able to download the slides. It is now my pleasure to introduce session 14, Success in the New Normal, Integrated Data to the Masses. It will be presented by Cy Johnson, Chief of Staff, Renown Health. Enjoy the session.
Thank you for the introduction. Hi, I'm excited to present to you the story of Renown Health and how in the past year we have begun and made significant progress on our journey towards how we use data in our organization and how we've applied that in some special cases this past year. We've had a lot of success integrating data to the masses, and I'm excited to tell you that story. Here's a quick agenda, things we'll cover in the next few minutes. I'll tell you a little bit about Renown Health, discuss how we're getting data to the masses and why that's so critical in the work that we're doing right now. We will talk about what we've done with the strategy and how we've used this capability in our COVID-19 work, which has been very significant and high impact. Also talk about best practices and how we've accelerated different aspects of our learning journey this past year, which hopefully might be helpful for some of you in your work back at home. And then we'll talk a bit about our results and how we plan to move forward from here. So that's our agenda today. Objectives for this session: we will demonstrate the critical importance of data and analytics. I think any of you who are involved in this conference will have a lot of background and insight about how critical data is in healthcare today, but we will talk about that and demonstrate it. We will identify how to use analytics to inform organizational decisions. I think that's a critical aspect for what we've been doing with data at Renown and in our work with Health Catalyst, and I'll share a number of examples of that. List best practices for learning from this improvement work. And we'll discuss practical applications for predictive analytics and some things we've done with that. So those are our objectives for today. So let me start with a little bit of background related to Renown Health. Renown Health's mission is to make a genuine difference in the health and well-being of the communities that we serve. We are Reno's and Northern Nevada's only locally governed not-for-profit healthcare system. Our healthcare system in this region is made up of 3 hospitals totaling around 950 beds. We have an employed medical group with more than 250, actually now more than 300 physicians. We have a health plan which has now around 150,000 members, which includes both commercial market segments and Medicare Advantage market segments. So a very diverse health plan representing quite a large percentage of our total community. In Reno, we have a population of around 500,000. So our 150,000 member health plan is a fairly significant element of that population. Renown has about 6,500 employees. We seem to be pushing closer to 7,000 as we continue to grow recently. We are the trauma center for this region, certainly in Reno, but also the larger area. We are the primary trauma center in between Sacramento and Salt Lake City, so it covers quite a broad rural geography. We have, as a trauma center for the community and the region, a very busy emergency department. And I think that gives you just a flavor for who we are, our size and scope, and what we do here in our organization. With that background, this is a graphic that some folks inside Renown, affectionately or not, sometimes referred to as the Uno card. For me, I'm not sure, doesn't feel that affectionate since I was involved a lot in creating this. It seemed like it was a lot more than Uno, but that aside. I'm just gonna briefly walk around this card with you so you get a sense for how deeply data and data strategy is embedded in Renown strategy as a whole. the center of this is about the people that we serve. Everything that we're doing is obviously about the people that we serve in our mission. And how we do that is sort of going around this card, some of the building blocks that tie into data. As we looked at where we are with the broad context of our strategic plan being population health, that's been the case for probably at least a decade at Renown. We looked at where we are in that journey and what we needed to do in the next 2 or 3 years. And so I'll start on the top right, infrastructure optimization. We knew that in order to support our population health efforts and to better take care of this community, we needed to have the infrastructure to support that work. Principally, you need some buildings and you need that type of infrastructure, but primarily our effort is focused on how we get access to and better utilize the data that supports care improvement in the value of the care that we deliver, how we manage care outside of the hospital or outside of our clinics. You can't do that without a lot of information about the population that you're serving, where they are at this moment in time, and what kinds of services would best support their health. And so that infrastructure optimization box is all about data. Network development and integration, that ties to data in that we have a diverse set of services in our community and a broad mission. As our data has existed in the past, it exists in silos. And so the need to integrate that information so that we can connect both what's happening in the clinical environment and what's happening from a health plan perspective and what's happening from a demographic perspective as the population changes. All of those things needed to come together from a data standpoint to support how we better deliver care. And so that's the yellow or the integration aspect. On the reduced clinical variation, that's sort of where it all comes to bear at the bedside. With the right information, with the right tools, we can then know better, more precisely how we're doing and where we can improve. And so as we build the infrastructure and integrate the work, it's all about then applying it to improve our clinical care. Innovation is another aspect that overlays all the work that we're trying to do. As we think about our future at Renown Health, it's not our goal to just follow the crowd. We would like to be ahead of the crowd, and we're willing to take risks to push ourselves in cases where we know maybe the probability or the possibility of failure is higher. But hey, the healthcare industry is not known for being the most out in front of all industries in our country, and we think it's worth pushing that threshold as much as we can. So as it relates to data, we're interested in knowing how to have the right data and leverage it and use it for innovation, as well as any other innovation opportunities. So as you look at that, I think the takeaway is, in order to serve the people that we're here to serve, we believe that we've got to create the infrastructure, a significant portion of which is the data, so that we can know more about the people that we're serving and where they are and how we can better help them, integrate that information and apply that to improve their care. So that's a little bit about our strategy and how data fits into it. As we entered into this step of our journey and our strategy and into the data aspect of it, the first bullet there, we still need to democratize data, is for me about culture change. So historically, as I think I've already said, Renown has had data. We've got great source systems. We've got a lot of other great infrastructure in terms of technology, but what we had not done until now was to tie it all together in a way that we could get the data from all those source systems, put it together and make it available to all the end users who could then improve care and improve the work that we're doing by using that data. And so these efforts at Renown, data was available in the source systems, but it required a significant lift for our technology team, our analytics folks, and our operators and clinicians to get access to different pieces of the data to try to use it. And when you think about the diversity of all the work that we are doing at Renown, we need to make it efficient for everybody who needs the data to access it. There can't be too much friction in that process, too much delay, if we're going to achieve all of our goals at the strategic level that we intend to. So our goal here is to change our culture from one in which data is available, but only if you do a lot of work and only if you spend a lot of money, which makes it available to only a few people, and instead make it available to everyone and change the culture so that everybody has access to it, uses it in real time, learns the improvement processes that are associated with how to use that data in a deeper way, and then by doing all that, get to change and improvement in the delivery of frontline care and in how we help the community be healthy when they don't need frontline care. So culture change is hard, and this critical need for data and analytics and how we use that to make business decisions and to drive improvement in clinical care, it has to be widespread and almost a cultural change for us to be as effective as we need to be in this space. Spreading data to the masses. As I said in our agenda, I'm going to cover different ways we've progressed with this use of data in the past year. This one for me has been the most important. This one for me is the aspect that's the most about the culture change and will have the biggest impact on the organization in the long run as we move this forward and do it right. What we have set out to do in data to the masses is, as I've already said, make data available to everyone, our frontline clinicians, our frontline operators, our leaders. And in order to do that, we have needed to take a lot of significant steps. So how have we done it? I think the first step is focused on, I think, the fourth bullet there. As I think about the journey with data, it starts from the place of we don't have that. Data doesn't exist in our organization. It moves then to, okay, now we have it, and that's good. But then as people start to utilize it, very frequently, the first response to seeing it is, well, it's wrong. So then you got to go through the improvement process of that step. And then once that's corrected and everybody feels comfortable with the integrity of the data, then you start using it and learning from it. And then the improvement cycles and how we do our work and deliver care and make better decisions start to happen. But the first step is you have to go from I don't have data to I do have data. And that's been the threshold that this data to the masses goal is trying to cross, the threshold of the data is actually there. The second piece of this that I would call out is the learning to ask the right questions, which is the second bullet here. As the data has become available technically, how users access the data and how the communication occurs between those who know where it is and those who want it. We've had a lot of learning in the past year trying to refine how that happens. Early on, there's a bit of friction in that space. An end user would say they would request whatever the specific data element was applicable to the problem they were trying to solve. And inevitably, on the technology side, rather than just accessing the data that was readily available, it would get lost in translation that data was readily available, and it would become a custom request as the technology folks would hear it. And so we're not getting data to the masses because the way requests were presented and then understood on the technology side, it turned into the belief that customization was what was necessary. And with customization then comes long wait times, lead times to get the work done on the technology side and then get back to the end user, and you guys know that cycle. So in order to avoid that, what we have learned, so here's one of the learning points that I think might be useful for some of you in the audience. I spent quite a bit of time on this myself, contacting technology people myself. I'm not a technology expert, consider myself more an end user type, but contacting them, asking the questions, seeing how they're translating and trying to go back and forth. And what we got to was, you know what, there's a menu, guys. We can order from the menu rather than, and if we do that, then we won't hear the requests as custom. We won't be hearing it as I want to make a special hamburger that has exactly these ingredients. We'll instead be hearing it as I want a Big Mac or I want whatever the specific menu item is called. And when you have the same words on the technology side and on the operations or clinical side, you can then go straight to the work, get the data that's already there and move on and avoid the misunderstandings that create a lot of customization. So my recommendation from this learning to you is that think about how to define what you're asking for and what you're trying to create in common terms, and teach both the technology folks and the end user folks what that language is, create a menu, and it becomes a much smoother transaction. It took us only 3 months to figure that out, so maybe we're slow, but you guys will be much faster and that'll be great. So learning to ask the right questions was a huge step for us in between we don't have the data and then crossing over to we do have the data. Knowing how to access it and ask for it was critical to crossing that threshold. And then discovering the analytics solutions that can be applied rapidly in a variety of use cases. That's where it was so critical that we focus on tools that are available out of the box rather than custom tools. If we allowed each request to become a custom request, we were never going to be able to get data to the masses because of the lag time and the inefficiency that's embedded in each request being custom. So we had to be, I particularly from a leadership perspective, had to be very, I think, firm in communicating the expectation that we were going to use the tools that were available out of the box and we were not going to create custom tools initially. We'll get to customization later, but in order to solve most people's problems most of the time, we needed to start with what was out of the box. So those are a lot of the things that we've done with data to the masses and how we've turned that strategy into something that's become effective and people are now accessing the information. So let me talk to you now about one of the most critical data applications that we've used as we stood up this system in this past year. As we were just in the stages of completing all of the technology infrastructure build requirements and transitioning to making that available to our teams, COVID-19 hit. And so it was late February, March, that time frame, and we found ourselves in incident command setup, looking at all of the things going on in the community and around the nation and the world related to COVID-19 and spending the 24/7 kind of effort that was required to make sure that we were ready and that we were prepared to support our community and make sure that they had the services that they needed or may need in the future as COVID-19 evolved. So as we were doing that and we were facing the different unique challenges that COVID-19 created, we could see that we needed access to information that was assembled from many sources in order to know what we needed to know and to manage it appropriately. So it was a great application for our data set and our tool sets that we now had available. And so what we did is we pulled the information from our EMR, from our supply chain, all the different source systems, pulled it together and created a dashboard that we used in our incident command structure. And we've continued to use going forward as COVID has moved for us from incident command to more of an normal operational setup, if you want to call it that. We continue to use this data source. So what it gives us is both information about what our COVID-19 volumes are and what our experience has been recently, what our trends are, all of those sorts of things. But it also can give us information about some of the critical aspects of COVID-19, like do we have enough PPE and how are we doing with lab turnaround times and lab supplies and all those sorts of things you can't get out of one system. So I was very thankful that we had invested in the data infrastructure that was necessary to create the opportunity to efficiently manage this crisis. And this dashboard is one example of some that we've used to help us with that. It's a great example of how data has been used in our decision-making process and in our process for improvement. Another application for the data as it relates to COVID-19 was the clinical quality component. So yes, we needed to make sure that we had the right PPE on hand and the lab supplies and the bed capacity and the staffing and all the different things that were fundamental to addressing this challenge. But also, once we had patients who had received care, we were interested in knowing, obviously, how did we do and where were there improvement opportunities. And so we created this dashboard early on as well. We were able to put this whole dashboard set together within a couple of weeks. This one gave us line of sight to how are we doing from a clinical perspective? What are our lengths of stays? What's our vent utilization? What's our ICU ratios? All those basic things. And that really helped us with our clinicians keep an eye on that we were staying current with what was going on and that our performance was at least as good as, if not better than, what data was available from other communities. And our experience, frankly, was that I feel that we did a really good job. We did have a lower ICU utilization rate, lower vent utilization rate. Some of the key indicators were favorable for us, and I think it's because we had our eye on the ball and our clinicians had their eye on the ball and making sure that they knew what was out there and how we could best provide care with this new unique situation. So using data for our COVID-19 response, both for operational reasons and for quality reasons, was fundamental to how we made our decisions and how we manage that crisis still today. I'm going to shift to another example for how we've used our data platform. And this one is more on the innovation side. So Renown Health, about 3 or 4 years ago, created this project called the Healthy Nevada Project. It's a collaboration of Renown Health and our Institute for Health Innovation and the Desert Research Institute, which is a public entity in our community that has historically been involved in water quality analysis and air quality and different things that are not normally incorporated into healthcare consideration. But we thought with this initiative with DRI, if we could combine environmental factors and data about the environment that the community lives in with clinical information from our history, from our EMR and other source systems, and then add to that genetic information, that we'd have a really powerful data set to improve care in our community and in our region. So that's the Healthy Nevada Project. It's a combination of those three streams of data, which is a unique combination. And the design of it was to apply to how do we improve the health of our community. As we launched that now 3-4 years ago, we had significant interest in the community. We had 50,000 participants enrolled in the past few years. We had I think about 10,000 in the first week. So it was very quickly ramped up, and there was a lot of interest. As I take that now to the present time, when COVID-19 hit, we had already built this data set, and we used the population that we had a relationship with here that was a part of the Healthy Nevada Project, and we outreached them early on as COVID-19 was emerging and asked them in a survey format about their risk factors for COVID-19. Have they been traveling overseas? Were they involved in large crowd events recently? Different things like that. Were they experiencing symptoms? And what that allowed us to do by adding that data to this already rich data set was to understand, before events had really progressed, what the risk profile was in our community, at least broadly, where some of the hotspots might be. And it helped us prepare in a different way early for what the implications of this pandemic could be for us in this community. I think what's really exciting for me about this application is how we may use it in the long term. So right now it's still kind of fast and furious with COVID-19. There's no cures, no vaccines. And there's still a lot of learning happening in the scientific community trying to figure out how to better manage this disease or eradicate it. And so as we move forward and all of those learnings begin to come through, how this data will inform us about our community's experience and different risk factors and how we can apply the learning in the future to other events, I think will be very exciting. So this is an example of, again, a more innovative project that Renown Health has been leading and been primarily involved in, and how we are bridging that in the COVID-19 environment and what we may do with it in the future. It's something we're very proud of at Renown Health. So those are a couple use cases and how we've used data to make decisions and improve care. Let me go to another. This example is more, I'll say, traditional. This is about frontline care in our acute care environment and our outpatient environment. And so as we built our data infrastructure and our capability to use it, one of the things we did early on as we thought about, okay, we want to bring data to the masses, we want to innovate, we want to do all these different things. Where are our opportunities for quick successes in our clinical frontline environment? And so we looked for those services or service lines where we knew we had strong physician leaders, strong operational leaders, engaged teams, people who were already focused on driving improvements in care, even though they may not have had the best data resources to support that effort in the past. COPD was one of our primary. And so what we did in this case was we took that team, organized them, put them together with our data experts and our process improvement experts, and then worked with them over the course of some months to look at where we were in COPD, what our opportunities were, both inpatient and outpatient, and where our improvements might be. And so that was another application of how we used our now more capable data set to derive frontline care improvement. And you can see on this slide different accomplishments that occurred in both our outpatient and our inpatient environment. I think for me, what's important about that is that there were many, not that there was any single line item that was particularly standout. I think that's a part of the transition, I think, for us, moving from an environment, data environment that was a little thin to one that's much more rich. You don't have to focus on a single bullet, a single priority. You can focus on the continuum, in this case with COPD, and see the improvements available across that continuum with the right data in real time, and then work on it all simultaneously because it's all interrelated. So I think it's the portfolio of bullet points here is, I think, more important than any one bullet. This gives you a sense for some of the data and some of the improvements that we've seen in our COPD work. Some of this improvement occurred prior to our investments in an enhanced data infrastructure. But that's to my point earlier. I think early on, it's important to select those teams that you know are interested in that improvement work and will use the data and want to learn more about how to be more effective. And so you can see we were already improving, and we've continued to improve with the use of a better tool set and incorporating that tool set into our improvement opportunities, our process improvement teams and their work mixed in with data and with our clinical and operational leaders. Let me take that COPD example and then apply it to another case where we've used this, our data tools in ways that leverage our population health strategy. So as we moved into the COVID-19 environment, and we knew a number of COPD patients who were quite vulnerable, obviously, to the COVID-19 disease. We thought about, okay, we've got these teams together and they know a lot about this patient population, have been improving care, but now that patient population may not be able to get into pulmonary rehab. We had to shut that down because vulnerable patients all in a closed space, not what you do in COVID-19. So many of the services that were built into how we provided care were either modified or in some cases not available as COVID-19 emerged. And so as we think about how do we manage this population when they're not in our offices or in our hospitals, again, back to the data. So what we did is this lists different illness risk for COVID-19. If you've got different pre-existing conditions, you may be more vulnerable to serious illness with COVID-19. And knowing that, we used our data systems to create a predictive format or formula for how we could know which of those patients who might have some of those diseases need our attention now, even though they're not able to come into our offices. And so we put together a tool pulled from our data resources and looked at what's the risk of readmission over the next 2 to 14 days for COVID-19 based on these different conditions. And so what you see there in the slide is a graphic just describing how we move through that. So you might be a specific case, Marilyn, 75-year-old female who is a smoker, has COPD, admitted to the hospital relatively routinely. How does she compare to other patients? What were the admission criteria that they had in common? And as we thought about interventions, both in COVID-19 and things we wanted to learn for the long run, how effective were those interventions? And so as we pulled all that data together, we were able to create the formula that gave us a sense for risk stratification. Is Marilyn, in this case, more at risk for a readmission or an admission, or less at risk? And based on that, what kind of intervention can we do now? Maybe outreach to Marilyn and support her managing her illness so that it doesn't escalate in this COVID-19 environment. So we had a risk stratified patient population, and then we could have our care managers outreach to the different patients that were in the right, that were the right ones to reach out to. Without the data, what we had is a community that we wouldn't have known who needs our outreach and who doesn't. And that would mean we can't outreach at all because you can't call 500,000 people at one time. And so the data gave us the opportunity to target what we needed to do to help those people who would be the most vulnerable potentially, and help them stay healthy and not need more services in this higher risk environment. This slide gives you a little bit more technical picture of how some of the formulas were built and how we use the data tools to create that. So we did we normalized the scoring system around a score of 1 being the highest probability for admission, and then stratified the population. We pulled from the data set different risk factors. In this box, in the blue box in the center, you can see readmissions in the past 6 months, whether or not the individual had COPD, CHF, or diabetes with complications. And so with that, and then putting it into a formula, we were able to do the risk stratification. So a lot of different case examples. Ultimately, what we are after, as I've said a number of times, as an organization, why we have made these investments in both in the tools and in teaching our people how to use it, is that we believe they're fundamental to our ability to support and deliver on our mission, which is to care for our population and our patients. Some of the results that we've talked about here with some of our case examples. In 1 week, we had more than 14,000 participants submit COVID-19 data to the Healthy Nevada Project, which we were able to use very quickly before there was data available from many other sources. We were able to use that to know how we should best respond to that disease in the right scope and scale and with the right interventions. And so that was a critical success factor for us. The tools we used then as the COVID-19 pandemic emerged to help us know where we were with our critical resources so that we could provide the care we needed in that environment was another fundamental success in how we've used our data capabilities at Renown Health in the past year. And that we could stand that up in a very short period of time, 2-3 weeks, was critical. If it had taken 2-3 months to stand up, it would have been too late. And so the speed to turn around on those first two examples was so critical, and is why I think the data infrastructure investment that we've made is so fundamental and so critical. The third bullet, third section in results there, which again for me is my favorite, the data to the masses, helping everybody in our organization understand that they have access to this information, that they need to use it, the use of it done right will help them improve care and help us collectively serve our population more effectively, has been critical. And I think while we're still early in that journey, I think we've progressed well on the technology side. We're still early in the utilization side. Some of the comments that I shared earlier about getting over some of the first thresholds for success in the utilization side, I'm really excited about, because I think we've just in the last few months gone from only a few who really sort of believe it and know it and use it to now hundreds, and soon it'll be thousands who know how to get into it and make valuable use of the tools. And then the last result, which I think is about long-term improvement, is that we've been able to use the data and then set up how we use it in such a way that over time we'll be able to learn about how our care delivery is done and how effective it is. And in cases where it could be more effective, the data and the way we're doing the work will tell us where our learning opportunities are going forward. And then do that over time times many different case examples. And I think it will have a huge effect on and make a real positive difference in how well we're able to take care of our community from a population health standpoint. Key learnings and recommendations. Without data, I don't know how you manage COVID-19 as a healthcare system. You really have to have line of sight to all the critical resources in order to be ready for sometimes unexpected shifts in the demand for your services. Data and analytics is critical to effective COVID-19 response in our experience. Another learning, flexible analytics solutions to pushing out data to the masses. I don't know how a healthcare organization in 2020 can be effective if they're not leveraging data to know more about the people that they're serving and their patients in their communities right now to improve the services they're delivering. If you're not doing that, I would be concerned about long-term success possibilities. It's fundamental to delivering care in 2020 and moving forward. And being able to set up your infrastructure so that it's available and so that it's flexible and can adapt quickly to changing circumstances and set it up in such a way you can learn from it is really critical, I think, for long-term success. How you ask questions is, for me, it was the most frustrating, but also one of the funnest learning opportunities in this journey. It was, for me, a source of great frustration early on to know that all of this capability existed, and at the same time, nobody was using it, or few people were using it. And that frustration and that need, that understanding of how critical the use of that data is, led me to lots of fun explorations with our team, both on the operations side and the technology side, and a lot of interactions myself, trying to learn how it is that we can inform ourselves about what's available and inform ourselves how to use it and use it effectively. And seeing the lights go on has been really exciting and invigorating for me as a leader at Renown Health. So hopefully some of that content was meaningful for you and it represented things you can take home and use in your own journey. It's been an exciting journey for us in the past year, and we're excited to continue it. I think, we have had some successes. We've certainly had challenges along the way. I'm really excited about what we're going to be able to accomplish this year and the year after that, as we have a large community of users who really leverage the capabilities that exist and use that to drive care improvements and improvements in how we take care of our population. Where we'll be 2-3 years from now is really inspiring for me. And I hope it will be for you as you guys continue your journey. Thank you for taking your time with me today.